Good evening, everyone. I'm Martin Trope, sitting at home here in Philadelphia, and I hope that you're having a good day wherever you are and whatever the time. Today, I'm going to talk about the treatment of post-endodontic disease. This is something we previously talked about in terms of retreatment, and the assumption was that there was a failure, and the assumption, of course, of a failure is that there's symptoms or still signs of disease, which, as you know, in endodontics is a sign of a radiolucency. Now, post-treatment disease, we divide into different categories, if you will. The first would be a persistent lesion. So the treatment started with a lesion present, indicating or suggesting very, very strongly that the root canal system is infected, and at a post-treatment follow-up, or because of symptoms that do not subside or develop later, the lesion is still there. And this is generally thought to be due to a failure in the primary treatment to get the microbes below a certain threshold, and of course then to seal the root canal and the coronal restoration so that the microbes would stay below that threshold, and this is an indication of a failure to do that. But in this case, in a persistent lesion, there is a very, very small chance that the original microbes may have been extraradicular, meaning outside the root canal, so that the initial root canal treatment actually did not focus on them, and so the treatment was could have been successful in terms of the threshold internally, but there's still microbes outside the root canal, and as I'll show you in the following slides, this is very, very rare. And also there is a theory that in certain cystic conditions that there could be what we call a true cyst, which again is a self-sustaining cyst that cannot be affected by a root canal treatment. The next thing we talk about in post-treatment disease is recurrent. So this is a lesion where the area and or the symptoms would have initially got smaller, and the symptoms go away and everything is looking pretty good, and then things reverse and become negative again in terms of a lesion or symptoms. And this sort of indicates that the threshold of microbes in the initial treatment was lowered. The microbes were lowered below that threshold, but because of space left behind or persistent leakage due to a poor coronal seal or a poor root filling, that the microbes were able to multiply again and regain a volume above the threshold, if you will. So this would have got smaller initially and then gets bigger again. And then the emerged lesion would be more related to a vital tooth, which, as you all know, a vital tooth does not have a lesion to start with because a vital tooth is not infected. And then due to a poor aseptic technique, or again, a poor coronal seal or poor root canal filling, the microbes are able to get into the root canal system and multiply above the threshold so that a lesion develops. So these are all failures or post-treatment diseases. And then the question is, what is the approach to these particular cases? Because a case that has been treated already creates problems that the initial case did not have, and we have to really think very, very carefully before we choose how to go about treating these cases. So if we go to the factors involved in these failures or post-treatment diseases, 90 to 95% of the case, it's intraradicular infection. So this is a very important bit of knowledge, because then we have to treat the infection intraradicularly, which means we either have to treat it with a new root canal treatment and a new disinfection protocol, that's what we call a retreatment, or we have to treat it with a surgical approach, which is not really an approach where we focus on the microbes within the root canal. We're actually entombing the microbes within the root canal with a good seal apically. So even though we know that the root canal is infected, those microbes in the root canal cannot communicate with the periradicular tissues, and because of that you'll get healing. Now, as you can see in this slide, extraradicular infection is very, very rare, but is possible. So this is an infection outside, usually with a plaque on the outside of the tooth, but there could be specific microbes that are able to survive in the periradicular tissues, and obviously neither the initial treatment or the retreatment is going to be effective in these cases. Foreign body reactions have been reported, but very, very few, and then the true cyst, which I've already discussed. There's been a lot of studies about what microbes are involved, and an interesting finding, which I personally don't think is that important, but it's certainly, if you're interested in retreatment and you're studying about retreatment, you're going to hear about this all the time, is the microbe Enterococcus faecalis. And Enterococcus faecalis is not a very predominant microbe, if you will, or doesn't stand out when you look at asymptomatic periodontal lesions, which are primary lesions. However, when you look at retreatment cases and the microbes that sort of stand out there, apart from the universal microbes in the PCR, the E. faecalis microbe, Enterococcus faecalis, which is a unique microbe in that it's facultative anaerobic. We always think in primary endo about obligate anaerobes in the apical third. So this is an interesting microbe, and it's interesting because it is very, very resistant to our common treatments of sodium hypochlorite, calcium hydroxide, etc. So it sort of rings alarm bells about should we be changing our approach, etc. Personally, and this is a personal interpretation of the literature by me, I think Enterococcus faecalis is a very, very strong laboratory microbe, meaning that it grows under very, very tough conditions. It grows under all conditions in a laboratory. So that in a retreatment case, it gives the false impression that it is predominating, whereas I think it's not more important than in primary endodontics. So I don't think we should change our protocol too much because of this Enterococcus faecalis. Now, one or two of you might be asking, what does change my protocol mean? Well, for example, chlorhexidine, 2% chlorhexidine in water is much more effective against E. faecalis than, for example, sodium hypochlorite or calcium hydroxide. The question could be, should we change to 2% chlorhexidine in water as an irrigant throughout a retreatment? Certainly nothing against it. Chlorhexidine has its disadvantages, but again, in my personal opinion, Enterococcus faecalis is not as important as has been made out in the literature in the last few years. Why that's important, of course, is all the research, they grow Enterococcus faecalis and test new techniques and new treatments against it. And of course, if it's not as important as I suggest, then those tests are sort of not that valid, if you will. So biofilm is important. And when you have an established root canal infection shown by an established lesion, we expect to find biofilm on the root canal wall. Now, biofilm is plaque like any other plaque, like periodontal plaque, etc. And as you can see in this slide, biofilm is 1,000 times more resistant than the corresponding planktonic bacteria which are floating in the main canal and are relatively easy to wash out. So when you have an established lesion, particularly when you've already treated that case, then this biofilm creates a tremendous problem for many, many reasons. One is the files that we've been using up to this point in root canal treatment are round, and the canals are not round. So when a canal is being treated, generally we've got a lot of debris, we've got a root canal filling material, and we've got gunk, if you will, in these irregular areas, which hide and protect even more this biofilm. So we have a tremendous challenge to get to the biofilm, and then once we get to the biofilm, we have to scrape it, because as with periodontal treatment, you need to disrupt the biofilm physically so that irrigants, antibacterial agents, etc., can then get at the exposed microbes and kill them, etc. If a disinfectant goes against the intact biofilm, as has been shown, the intact biofilm can resist common antibacterials very, very well. So what we try to do is, number one, get to the biofilm, and we need adaptive instruments that I'm going to discuss later in the lecture. And then once we've got to the biofilm, we have to disrupt it, bring it into the main canal, and then irrigate it out. Here at the bottom, you can see an example of an extra radicular infection. So this is biofilm, but on the external surface of the root. And this is one of those rare 5% of cases. And this is, as I mentioned before, a particular challenge, and neither treatment nor retreatment would be effective against this type of biofilm. And again, another example of a treated case where you have biofilm in the isthmus connecting the two main canals. And again, a particular challenge in retreatment, it's a challenge in primary treatment as well, is how do you get out this gutta percha without pushing some of it into the isthmus, blocking the isthmus, which then does not allow irrigants, agitation, any different type of agitation that you might use in order to lower this bacterial count. So there we have therapy alternatives. So retreatment is the one alternative that I'm going to specifically talk about this webinar. I'm not going to deal too much about apical surgery, just discuss it in terms of an alternative treatment to retreatment. The third possibility, of course, is extraction, something that I think has been chosen way too much in the last few years, but luckily the implant era is balancing, and the attraction of implants is not as great as it was, because we now know that any tooth that's susceptible to periodontal disease, the implant, or any patient who has a tooth susceptible to periodontal disease, their implant will be just as susceptible to implant disease. So the implication and the assumption that I'm making is that we as dentists watching this seminar want to keep teeth as much as possible and at all costs, if you will, and extraction is a choice of last resort. So the main question here is retreatment or apical surgery. So we're dealing with intraradicular infection. So if all is equal, retreatment is the treatment of choice, because retreatment is the treatment compared to apical surgery, of course, which will then take care of the intraradicular infection. And if the retreatment procedure is successful, we will have an extremely low microbiological count at the end of our treatment. Ultimately, hopefully in a few years or a few decades, we'll be able to sterilize every root canal that we treat and retreat, and then of course our success rate will be 100%. With apical surgery, we confine the microorganisms into the root canal and limit their capacity to communicate with the periradicular tissues so that healing will take place. And we depend on that plug, if you will, to seal for the rest of the patient's life. So obviously as I said, all things being equal, the retreatment would be the treatment of choice. So with a retreatment, you've got a failed treatment. I'm sorry, I'm going to go back. And the idea is to get back in there and to clean everything out, disinfect with disinfectants, and then get rid of all the microbes. Let's dream, and then seal everything perfectly. Once we're dreaming, we might as well dream again, and everything will be okay. Now, what you have to understand, of course, is when you do this, you are sacrificing tooth structure with the common instruments that we use today. There will be very, very few root canals where after you fill the retreatment procedure that there is the same amount or of dentin left behind. In many, many cases, a significant amount of dentin will have been removed in order to do an adequate disinfection of a treatment that has previously been done, and this can jeopardize the survivability of the tooth, particularly if the previous treatment has had a tremendous taper. I don't have an example in these three cases, but if there's been a tremendous taper on the previous treatment and we have to get in there and clean and get to clean, fresh dentin, then we could jeopardize the survivability of the tooth. But these are three successful cases. You see a very, very poor treatment, disinfection protocol, very well filled, so we assume that the disinfection protocol was very thoroughly done, and at the follow-up there is no disease, showing successful disinfection and sealing of the root canal and the coronal restoration. Here, an additional issue is the post. So in this particular case, the post had to be removed, the root canal filling removed, everything cleaned and disinfected and refilled, and you can see again a successful result as evidenced by the disappearing periradicular lucency. Here is a case where the previous treatment was very, very minimal, and the difference, and in this particular case, this is what the root treatment should have looked like initially, and because it was so minimal, we were able to get a good result here, both from a healing point of view, biologic success, and from a survivability point of view, not removing too much dentin. But this is an exception really, because many, many times the previous treatment has already removed too much dentin, and now we have to go in there and remove more because we need to disinfect this root canal system. With apical surgery, as I mentioned before, we use a different approach. So the apical complex anatomy is removed, and then a 3 to 4 millimeter retro prep is made and filled with bioceramic material, and then the assumption is, and if done correctly, this is going to result in a very good result. And microsurgery today with modern techniques generally results in an extremely high success rate if the practitioner is a good microsurgeon and the tooth root is accessible. This is an extremely successful procedure, particularly since the advent of the bioceramics, which seal the cavity extremely well. So retreatment, as I said before, and I'm going to stress again, from a purely biological perspective, retreatment should always be attempted. And I've said this again from a theoretical or biological perspective, but obviously in many cases, this is not feasible or possible because the destruction of the root is more serious, if you will, than the treatment, than the benefit, if you will. So we go for the surgical approach. So as I said before, it's not always feasible. So the indication for retreatment would be one, a poor root canal with a poor coronal restoration that needs to be replaced. So with or without disease, if you have a poor coronal restoration that needs to be replaced in a poor root canal treatment, we feel that a retreatment is indicated. When there's no disease to start with, that would be a preventative root canal treatment. If there is disease, of course, to heal the disease. And of course, when a failure occurs, I've already discussed these failures, when a lesion does not disappear, or when a lesion develops, or symptoms do not disappear, or symptoms develop, then if feasible, a retreatment should always be done. Symptoms are always an indication of inflammation periodicularly, so that we assume that that inflammation would not occur without an active infection. So this is a direct indicator of a failed case. So what is the prognosis? And this is very important in choosing whether to do a retreatment or a surgical procedure. So this is a study in 2008 in the UK, and overall retreatment was successful 77% of the time. And this, you know, is not that great, particularly if you're comparing it with implants. Now I want to stress one thing. Implant definition of success is survivability, really. If the implant survives, that is considered a success. When we talk about these types of success rates, these are the presence or absence of lesions. It's got nothing to do with survivability. The survivability of a root canal treated tooth versus the survivability of a implant is very equal and very high, in the mid-90s. Now, important. If you take this 77% success and there's no periapical lesion, then the success rate is actually 93.5%. So these are the cases where you're doing a preventative retreatment because of a lost restoration or a poor restoration, etc. But in the presence of a periapical pathology or periapical lesion, the success rate is lower, and it's 65.7%. Okay? So you may think when there's a periapical lesion, we should do a surgery and not do retreatment. But we've got to look into this a little more deeply. So this is a very nice study by Gorni and Gagliani in 2004. And what they did is they separated retreatments into root canal morphology respected. So what they did was they looked at the apical third of the canal and defined it as an apical third that the retreatment could address. In other words, you could get to that apical third, the real anatomy without deviation, etc. And then the other group was the root canal morphology altered, where there had been something done in the initial root canal which really made them skeptical, and actually afterwards they were able to confirm that it was very difficult to clean that apical third. So if we look at a case like this, poorly done root canal, no reason to think we cannot get to the apical third. Case like this, the same. Case like this, the same. So that would be root canal morphology expected. And if there was no periapical pathology, 91.5% success. If there was periapical pathology, 83.6% success. So a very high success rate in these canals, even though there is periapical pathology, if you can get to that apical third. Now we get to cases where the apical third has not been respected, root canal morphology altered. That's one example. That's another example. And a third example. Here we have a completely different outcome. So if you've got no periapical pathology, then it goes down from 91% to 84%, but still, in my view, in an acceptable range. But this is the kicker. If you do have periapical pathology, the success rate is 40% if the root canal morphology is altered. So personally, this is my key. If I have a lesion on a tooth that's been treated, and I believe that I can get to the apical third, and there's no other reasons why I shouldn't do a retreatment, I do a retreatment. If, on the other hand, I am not convinced, or I am convinced that I won't get to the apical 3 to 4 millimeters with my retreatment, I don't do the retreatment because I can only offer the patient 40% success from that treatment. I go straight to surgery. If you're a general dentist or an endodontist who doesn't do a lot of surgery, you should send it to someone who can do a microsurgical technique with the most modern instruments, and then you can expect a low 90, mid 90 percentage success rate from the microsurgical procedure. So then again, if we can efficiently clean and seal the apical root canal system, we do non-surgical retreatment. If we cannot, we go to a surgical retreatment. All right, so how do we do it? Well, just to make a further point before we get to how do we do it, the coronal restoration is extremely important. And the coronal restoration, if there's leakage and coronal leakage, that would make apical surgery a very chancy procedure, if you will, because the microbes are continually repopulating the area. So we have to think of coronal leakage, and then can the tooth be restored after the coronal portion has been destroyed? And you know, you can get away with quite a lot. This is obviously a failure, obviously a very poor restoration, and you can identify where the coronal leakage is occurring. And this is a particularly iffy case because if I do retreatment, can I improve it? Apical surgery is also a little iffy if this continues to leak, etc. So this is my close colleague in Norway, Gilberto de Bellion. I don't know, I hope that his name comes up on the slides. I don't see it on my slide. And what he's done here is he's done a beautiful retreatment and then extended the coronal restoration below the bone level. So now coronal leakage is much less likely and hopefully has been inhibited completely. And in this particular case, as you see the follow-up, you see that at least initially in the first year, the lesion has disappeared, indicating that the microbes have been controlled and also the coronal seal is holding up. So let's now go through the clinical protocol. So the first thing we talk about very, very quickly would be key preparation or crown removal. Then we've got to remove obstacles. And what are we aiming for again? We're aiming for the apical third of that canal. That's where you get your biologic success. And we're aiming to get to the apical third of the root canal without destroying the root and jeopardizing the survivability of the tooth. So after that, we'd remove the coronal part of the root filling with rotary instruments or ultrasonics, and again with destroying as little tooth structure as possible. We use a solvent. There's a question mark here, but I'll answer the question immediately. Remove the middle and apical root filling with manual or rotary instruments, and then irrigation, intracanal medication, and a new root canal filling. So very quickly, I don't want to spend too much time. I do want time for questions. I'm assuming most of the audience are general dentists, and then I'm assuming that you have as much knowledge, if not more, of how to remove a crown completely with all these gadgets that we are able to get our hands on in order to move the crown without destroying the crown or destroying the tooth. If we cut off the crown, it has a tremendous, tremendous advantage from a retreatment point of view. First of all the caries can be removed. If you go through a crown, it's very difficult to see all the caries. Caries are microbes and they always will jeopardize your success. But one thing I want to point out with this picture, if you do remove the crown, you will make the retreatment more difficult in terms of isolation of the environment so that you can do a retreatment under aseptic conditions. So you have to learn to use this liquidam and other techniques in order to treat the root canal in an aseptic manner and take out microbes, which is the aim of the treatment and retreatment, and not put microbes into the environment, which is very difficult not to do and of course is completely counterproductive. Now, when there is an existing crown and you want to preserve this crown, and unfortunately this is very, very common. It's not really something we should aim for, but I'm practical enough, I'm in private practice, and I know that many patients will not accept destroying a crown, particularly if it's been made a year or two before, and having a new crown made. So we need and we have to go through existing crowns very often. So this is a setup that we may want to use, and basically here the diamonds are for the porcelain and the carbide burrs are for the metal. So if we look, talking about a crown with a porcelain covering, we would use the diamond to expose the metal. We wouldn't use the diamond to go through the metal. We would then use the carbide burr. You'll notice it's a long shank carbide burr because it has to go deeper than the diamond burr, which is just superficial until the metal is reached. And then we would go through the metal until we reach the gutta percha. And now we need to extend the access cavity, because in many, many cases, the case has failed because a root canal has been missed, or we have to remove a post, and in order to remove a post, you need 360-degree freedom in order to ultrasonically remove that post. So you're going to use either a carbide straight burr or a diamond straight burr, depending on what you're cutting. If you're cutting porcelain, you're going to use the diamond. If you're cutting only metal, you're going to use the carbide burr. And then you have space, and you need to have enough room to be able to find missed canals. So here is an example of a root canal done, and then there is a missed canal. Here is an example of a post. This has to be removed. That post will not be removed if your root canal, I'm sorry, if your access cavity is not large enough in order to have 360-degree freedom for that post to be removed. And then generally when we get to the floor of the chamber, we switch to long shank round burrs, and these are slow speed, and these could be, you know, any number of companies make these type of round burrs. So basically we're going to use the high-speed diamond or metal burr. We're going to use a low-speed burr at the floor of the chamber, and then we're going to start removing the gutta percha. And we want to be as conservative as possible, so we want to penetrate only into the gutta percha or previous treatment, if at all possible. So what I use is a very thin ultrasonic tip. You could use a thin orifice opener burr at high speed and try to concentrate on removing the gutta percha only. You're then going to, and this is an example, I personally prefer the thin ultrasonic, or you could use a common orifice opener. Then what I do is I place a few drops of solvent. So once you've penetrated into the gutta percha, now you want to soften the gutta percha. Okay? So I would add a few drops of solvent and let it sit for a few seconds, and then go to the next stage. And this is what I want to present today as something completely new. And this is the expandable nickel titanium technology, which is not made specifically for retreatment, but is tremendously useful for retreatment. So we have in the US, if you're watching this webinar from other countries, you may know this as the XP shaper and XP finisher. In the US, we call it the XP 3D shaper and finisher. And these are two instruments that are adaptive instruments, and they adapt to the shape of the root canal. The shaper is able to cut. The finisher is equivalent to a periodontal scaler and can move into almost every space available in order to get to these areas. So these work on the natural properties of nickel titanium. So when the instrument is at body temperature, it is stiff, and the molecules are stiff enough so the file will get back to its original shape. When you cool the instrument, that's like room temperature, the molecule bonds are not stiff, so you can manipulate the instrument and it will not snap back to its preformed shape. So here is a video just to show.
This is no ordinary paperclip. In fact, it's made from nitinol, and it has some unique qualities.
So it can be manipulated. And
let's bend it into a completely different shape.
At body temperature. So as soon as this paperclip is put back.
Okay, I think that should do. Now watch what happens when I drop this into some hot water.
It goes back to its preformed shape immediately to the original paperclip. So this is how these instruments work. So this is the shaper, where it has been manipulated to be straight, and this is in its martensite form. There is a booster tip which allows it to follow the path of least resistance. So this will not make its own canal. It will follow the path of least resistance. In a retreatment, of course, that is the gutta percha. It has a 0.3 diameter, which is will make a 30 if required, and is an 01 taper, so very, very flexible instrument. When the instrument is in its austenite phase, it gets a snake-like shape and has the potential of an 08 taper. Now, of course, that's when it's free to expand without resistance. But in a particular case, like a very tight canal or a canal that's already been filled, this is going to squeeze down and then only expand in time, if you will. So here is the booster tip, and you see a passive tip which will not cut, so it will follow any path of least resistance, and behind it is a six-sided, what is equivalent to a carbide burr, which really cuts from a 15 to a 30, and this gives the size of this instrument. I'm going a little bit fast here because for retreatment, this is not as important as if I were giving a lecture on primary endodontic treatment. The big advantage for primary treatment, but particularly for retreatment, is that because it's an 01 taper and it's snake-like and it can expand, when you go into a canal with this instrument, most of the space is empty. Now, if this is a filled canal with gutta percha, most of the space would be gutta percha. If you take the standard round instrument, the instrument takes up the most of the space. So it's very difficult for this instrument to take out the gutta percha, number one, and number two, this instrument is going to push the gutta percha laterally and make the situation worse because it's going to push the gutta percha into the irregularities. This file can wrap around the gutta percha and bring the gutta percha out. So if we look at the next slide, this is an unfilled canal. You see how the snake-like movement allows the instrument to work. And what this video is showing is as this instrument is working in the plastic block here, there is room for the debris and for the instrument. Because even though the instrument is cutting at a larger taper, the actual instrument is an 01 taper. So there's room for the debris and the instrument. And of course you can see it's moving eccentrically so that it's able to touch the walls. So now if we take this into a retreatment situation, now you've got a gutta percha point that has been removed coronally and it's softened with the solvent, and now this instrument has the ability to wrap around the gutta percha or gutta percha points or carrier and bring them out because of its rotary motion. So if you look at this video here and look very carefully, you'll see that the instrument is able to wrap around. When it starts to do that, I will show you, and you see here it's got its catch and it's wrapping around the gutta percha, and as it wraps around the gutta percha, so the pieces of gutta percha are pulled out. And if you use this instrument, the recommended speed for primary endo is 800 to 1,000. If you increase the speed to 1,000 to 2,000, you will remove this gutta percha in a matter of seconds. So let me show a video here. What you see here is this canal here has been started. There's been an ultrasonic in there. There's solvent in there. So the XP shaper has a catch, if you will, and now it's going to start to work. So it gets in there, you disengage it, move it at 1,000 to 2,000, and as soon as it engages, it immediately will pull out this gutta percha. And this is very, very, very quick. Another video I'm going to leave because I'm running out of time, and you see how we can retreat this case without over-instrumenting the canal. And this is what you will find, that if this is lateral condensation, if you will, the gutta-percha pieces will come out one at a time and in separate. If it was vertical condensation, then it'll come out as with the video. And you see here how there is room for the gutta-percha and the file, and it wraps around the file. And again, if you are going to go at 1,000 to 2,000 RPM, this will pull out in a matter of seconds. This is just to get out the main gutta-percha. This has not really cleaned the canal, but at the same time, it has not pushed the gutta-percha into the irregularities. For this, we need the finisher. And the finisher will get into all the irregularities in primary endo, and it is particularly useful for a retreatment. So this is, again, a picture of the instrument. In the M phase, you can straighten it out. It's a 2500, no taper at all. In the austenitic phase, it gets this sickle shape, which when it spins, has a 3 millimeter diameter, both for the tip and the bulb, if you will. But if you squeeze the bulb, the tip can expand to 6 millimeters. If the canal squeezes the tip, the bulb can expand to 6 millimeters. So when it's spinning, this is what it looks like. And when the tip is pushed and squeezed, the bulb can expand. And when the bulb is squeezed, obviously it's not going to be done with your fingers. It's going to be done by the canal. Then the tip will expand. Okay, so this gives you a tremendous capacity for movement. Now, when we go to retreatment, after you take out the initial gutta-percha, this is generally what you see. And unfortunately, even with the microscope, we only see this gutta-percha. Okay, this is what we visualize, and it's the least important of the entire treatment, but it drives us crazy, as all of you who have experience will know. Over here, we don't see it, but this is the important part, because remember, I've made the point that it's the apical third that determines whether you have a successful retreatment or not. So now the finisher will take care of that apical third particularly. Okay? Now the primary finisher, or for primary endo, has a 2500. For retreatment, what they've done is they've made the core just a little bit thicker, a 30. And that core will allow the instrument to be just a little bit stiffer. So you have the 25 instrument for primary endo and the 30 core for a retreatment. And this gives it a little bit more body, a little more stiffness, so that the gutta-percha can be removed. I still recommend doing the gutta-percha in the presence of, doing this finisher, in the presence of solvent, because that softens any gutta-percha there is. So again, in this video, you will see there's a little bit of gutta-percha left in this canal, and you see how the finisher as well there's space for the finisher and the gutta-percha, so it will wrap itself around and pull the gutta-percha out of the canal. Here is another example, a relatively, we would think, simple case, a maxillary incisor. It's done, normally, and then the finisher will go in there, and almost instantaneously you start to see these tissue tags, debris, and we just do this for as long as necessary, so that when we irrigate and redo the finisher, then nothing in addition comes out and everything looks very clean, and you sort of get this mirror-like cleanliness feel from the treatment. And studies have been done to show that after initial treatment with round files, I'm sure the shaper would be better, you get almost a 70% additional reduction of debris, gutta percha, etc. with this retreatment finisher. So to finish, I want to go over this again. We gain a starting point with the orifice opener or thin ultrasonic tip. And you do this in gutta percha alone. We place solvent, and that's to allow the shaper to get a starting point, because once it gets the starting point, it will wrap around and pull everything ahead of it out of the canal. Use a shaper at 1 to 3,000 RPM, and a used shaper can be used. A shaper that has been used before can be used. So the point I'm trying to make here is I obviously use the shaper for all my treatments, not only retreatment. Then I sterilize the shaper and I use a shaper that's been used for primary treatment for the retreatment. And that's because the snake shape, etc., is not that essential for retreatment. We're just using the shaper to get the bulk of the gutta percha out very, very quickly. Remove the gutta percha to the most apical point. Gain access to the cemento-dental junction with traditional glide path files. This is when you've taken out the gutta percha, but the gutta percha doesn't go all the way to the working length. We've got to then get a glide path of at least 1502 with glide path files, and then use the shaper all the way to the cemento-dental junction. And then we clean the apical 3 to 4 millimeters to at least a 30, which then allows your finisher to do the rest of the job. So again, canal entrance, solvent, shaper, we use as long as it'll take. It usually takes very, very little time to get the bulk of the gutta percha out. And then we use the finisher, and the finisher is used in a combination of sodium hypochlorite or EDTA for as long as it takes to get a clean look about your canal. And then ultimately, we would clean everything out very, very well with EDTA and use 2% chlorhexidine as our final irrigant, because that's so effective against the retreatment microbes. And here are, just before we finish, and I will address some questions, here are some cases, and I think I would like to stress how relatively conservative these retreatments are with this shaper and finisher. And that's beside the fact that we know that it's 70% cleaner than if we just use a round file to finish this case. So here we have, again, taking out a carrier, and the carriers come out very, very well, and you can have a very, very successful case. After taking out the carrier, the gutta percha is very short. You would gain your length with a glide path file, and then use the shaper again to at least a 30. That's the natural size of the shaper, and then the finisher does the real job in this retreatment case. Okay, I would like to thank you for attention. I see there's quite a few people in the classroom, if you will, and I'll be very happy to answer any questions. So I have one question. What do you use as a solvent? I use chloroform, but every country has different rules and regulations, if you will. So you could use oil of cloves or whatever is acceptable within your particular region. But you know, a traditional solvent which will make the gutta percha or soft and you know, let the shaper get a hold of the gutta percha. Are you doing retreatments in one visit, or do you use multiple treatments with calcium hydroxide? I don't do retreatments in one visit. Now, I must admit I don't have any research with the Shaper finisher to see if that gets the microbial count down to an acceptable level. But I'm a very firm believer in less microbes means more success. So I use calcium hydroxide in my retreatments. Remember, retreatments have higher flare-up rates than initial treatments, so that also gives you the opportunity, if you do have a flare-up, to deal with it. But I personally never do a retreatment in one visit. I use calcium hydroxide, and then when I come back the second visit, I go through the entire irrigation protocol again. So that would be sodium hypochlorite, finisher, for 30 seconds, wash it all out with EDTA, finisher for another 20 seconds, then rinse. I don't use the agitation with the chlorhexidine, 2% chlorhexidine in water, and let that sit for a minute or two, and then I would finish on the second visit. Thank you. Can I find the XP3D Shaper in Europe? Yes, you can. That's the XP Shaper and XP Finisher, and depending on where in Europe you are, it would be any company that represents FKG who make the instrument in Switzerland. So in the US, Brasler represents FKG, and they have named the instrument XP3D, but that's the same as the XP Finisher and XP Shaper in Europe. Let me just look. Do I use antibiotics when retreating symptomatic cases? No, I limit antibiotics only to cases where I have active infection. So I would have active infection with a flare-up, with a swelling, signs of a fever, etc., etc. But in the vast majority of cases, I do not use antibiotics. When I do final obturation for the case, there was a question, when do you do the final obturation? I think I've answered that. I think the question is directed at 1 versus 2 versus 3 visits. Basically, the biologic answer to your question is I do it when I'm convinced I've got the microbial count to as low as possible. Generally speaking, that would be in the second visit. Sometimes if I have particularly difficult time getting the obstructions to the gutta percha removed, for example, sometimes I can take a whole visit to remove a post, right? Then it would be 3 visits, because then the second visit would be the gutta percha, the shaper, the finisher, and then the calcium hydroxide, and I would come back and do the obturation after that. What is the rate of treatment failure if the endodontist creates a new canal due to instrument and drills it with gutta percha? If the endodontist creates a new canal due to instruments and I think what you're indicating or suggesting is that the endodontist ledges or perforates. Well, you know, as I say, this lowers the success rate. So the main aim of retreatment is to get to the apical 3 to 4 millimeters, the original 3 to 4 millimeters, and clean and shape that. Anything that deviates from that lowers your success rate tremendously. What is the rate of treatment failure? Again, I addressed that at the beginning of the lecture. If you have no lesion and you can get to the apical third, it's very, very high, in the high 80s, low 90s. If you do have a lesion and you cannot get to the apical third, mid 80s. If you have a lesion and you cannot get to the apical third, 40%. So these are the cases where I would go straight to surgery and not bother, if you will, with the the retreatment. Orange oil better than chloroform? I really don't know. I think both are equally as good. What is the best way to remove the carrier core? What is the best way to remove the carrier core? I cannot stress for you enough how successful I've been, and I think you will not get a better way to remove a carrier core than the shaper. And what the shaper does is that it allows, because it has such a thin core itself, it is able to wrap around the carrier and remove it. So you don't have to get on the side, etc., etc. Let's see. Stress the use of a rubber dam. I don't know. That's Robert Markovitz says stress the use of the rubber dam. Thank you, Robert. I think I took that for you know, just took that as a given, but I cannot stress enough, and I thank you, Robert, for reminding me that all of this is doomed to failure without a rubber dam. So we are dealing with microbes. Our aim is to get rid of microbes. It's particularly difficult in a retreatment case because it's already been blocked, etc., etc., etc. So you need to use a rubber dam so that you don't put yourself at any disadvantage. Without a rubber dam, your success rate will be lower. Also, you're using a lot of medicaments, chloroform, etc., etc. The rubber dam is the only thing that will ensure that your patient does not swallow, etc., etc. Liquid dam is the material that is used in order to stop the toxic effects of bleaching. You put it on around the rubber dam and then cure it. So if you ask any dental company for liquid dam, I think they will be able to help you. Do I use the same files for conventional endodontics? Absolutely. If you go back to my webinars on this site, you will see that I've given a webinar already about the finisher and the shaper for primary endodontics, and this is my standard instrument to be used. And tonight I just want to stress how particularly useful they are for retreatment cases, and I love to show them to people for retreatment because, of course, people like visual confirmation of what they're doing, and there's nothing more exciting than seeing the gutta percha come out in 1 to 2 seconds, and then the finisher taking out all of these tissue tags, debris, sealer tags, etc. These are things you can't see in the primary endo, but they happen with the microbes, and it's a very, well, it's my favorite instrument for primary endo as well. How long do you keep the calcium hydroxide in the canal is the question. And I keep the calcium hydroxide in the canal for at least 7 days, but no more than 4 weeks. So this is actually from research from primary endo, but I have nothing to contradict it, or I don't have anything for retreatment in particular, but I'm assuming that once you've instrumented, you've cleaned the canal, we're dealing with the same issues. So the 7 days, that's what it takes, the calcium hydroxide, to be able to move into the root canals. And then after 4 weeks, we assume that the dissociation of the calcium hydroxide into calcium ions and hydroxyl ions is complete, and it's not effective anymore. And we also worry after 4 weeks about the integrity of our temporary restoration. So generally, I have a window of 1 to 4 weeks with the calcium hydroxide. Okay, I think that's all the questions, and I think that, oh, there's another question here. Broken files, instruments, can you use the XP3D? I'm going to say no. And I mean, if you have a pathway of 1502, then the XP shaper will go around the file and maybe bring it out. But what you don't want to do is wedge the tip of the XP 3D shaper, because it can break as well. So I would much use an ultrasonic technique for this purpose. And even though I know there are people who have success with it, I wouldn't like to tell 312 people to do it, because there will be broken instruments if you do that. I'm going to answer 2 more questions because the time is up, and go with that. What is my opinion about chlorhexidine gel? Is it effective as calcium hydroxide? Chlorhexidine gel is a possibility and a very good idea, particularly in retreatment cases. So, you know, I think there's nothing wrong with that, and I think that it's something that can be considered to be a good alternative to calcium hydroxide. Okay, again, thank you very, very much, and I would be happy to answer any questions you have. You can contact me at nextlevelendodontics.com, and I will answer any questions individually. Thank you very much.